Thank you for joining today's PC-PCC webinar, Your Patients Are Waiting, Action Steps to Integrate Behavioral Health into Primary Care Practice. During the webinar, you'll hear from experts about practical insights to behavioral health and primary care integration. I'm Julie Shills. I'm the Director of Health Innovations at Mathematica, but more importantly, I serve as one of our 2 executive member liaisons to the PC-PCC board. Rob Dribbin from Merck also serves in this capacity and as a partner with me in this role. I'm so excited to facilitate today's webinar. For those of you who are not members of PC-PCC, I'd like to take the opportunity to encourage you to do so. Feel free to outreach to any of the PC-PCC staff and they'll help you learn more about PC-PCC and how to become a member. Just a little bit about PC-PCC and why my organization, Mathematica, is an executive member. PC-PCC brings together 60 organizations really committed to empowered team-based primary care and a high-value delivery system. You, as an executive member, you'll be an active participant at the table, join in a collective voice, also, directly and effectively respond to the healthcare environment. One of the really critical elements that I know we've had as a benefit of being a member of PC-PCC is the fact that the PC-PCC team has created such a nice relationship with the Center for Medicaid and Medicare Innovations. And we've had opportunities to have dialogue previewing some of the programs that even before they're rolled out externally, being at the table and having dialogue about that. Finally, before we start our presentation, just want to remind everybody about PC-PCC's annual conference. It's this fall in Washington, D.C., November 4th and 5th. Register now. It is worth your attendance. I know there's a lot of conferences you can go to, but this one is a good one. So moving on to our panelists, I'm now pleased to welcome all of our panelists, and they have been so kind in terms of, we have a slide of everybody's picture and names and roles and responsibilities. We have so much, we had several prep calls, and we have so much to talk about today that all of our panelists were gracious to let us forego the actual official announcing all of their roles, so we're going to pass on that, but please take a look at everyone we have participating as panelists today. We're doing a little bit of a different format. We're really excited about it. Stephanie will take the lead in organizing our thoughts as a presenter, and our other panelists will join in throughout the presentation and offer commentary and additional thoughts. So another thing to just tell you, use the chat function to submit questions. Chris from PC-PCC and I will be monitoring those questions. And as always, the presentation and the recording will be posted on the PC-PCC website. So with that and all the logistics out of the way, I will turn the presentation over to Stephanie. Thanks so much, Stephanie.
Great, thank you, Julie. And thank everyone on the phone for listening, and I'm excited to hear our discussion. Just to start with a quick disclosure, I'll be referencing a book that Larry and I co-edited, Integrated Behavioral Health and Primary Care, Your Patients Are Waiting, which we have a very small financial interest in, and we are both employees of the University of Colorado. To make sure that we're all on the same page and talking about what is integrated behavioral health, I'll just start by going over the National Integration Academy Council definition of integrated behavioral health. So integrated behavioral health is the care that results from a practice team of primary care and behavioral health clinicians working together with patients and families, using a systematic and cost-effective approach to provide patient-centered care for a defined population. This care may address mental health and substance use conditions, health behaviors, including their contribution to chronic medical illnesses, life stressors and crises, stress-related physical symptoms, and ineffective patterns of healthcare utilization. You'll notice that this definition is not specific to a particular model of integration, and as we go through our talk, we will also be largely talking about universal tips that apply to any model of integrated care. So now we're on the same page about what integrated behavioral health is. Why are we talking about it? Because integration is just better care. I'll spend the next couple of minutes giving a brief overview of why, starting with the background on why it makes sense to take care of behavioral health conditions in primary care. Behavioral health needs are not being met in our current system. The statistics in this infographic demonstrate a few key findings. First, behavioral health conditions are extremely common. 46% of adults will experience a mental illness or substance use condition at some point in their lifetime. Second, most patients with behavioral health conditions are not getting treatment or having trouble accessing treatment. 67% of adults with a behavioral health condition are not getting behavioral health treatment. And 66% of primary care providers report that they're unable to connect patients with outpatient behavioral health resources due to a shortage of mental health providers. And finally, patients with behavioral health conditions are most commonly being seen in primary care. An estimated 20% of primary care office visits are related to mental health, and 35% of children that are receiving outpatient care for mental health are solely seeing their primary care providers for that. Costs of care for patients with chronic physical health conditions are also significantly higher when they have comorbid behavioral health conditions. As you can imagine, having a mental health condition like depression, in addition to a physical health condition that's chronic like diabetes, can lead to increased difficulty taking care of oneself, including trouble adhering to a healthy diet and taking medications regularly. And as a result, more costs are incurred actually on the medical expenditures side, in addition to mental health expenditures. And that's what's being shown in this figure here. So in the bars all the way on the right, the dark blue bar is the average per member per month amount of cost of care for patients with a chronic health condition. This is averaged over the top 10 most common chronic physical health conditions. And the dark blue bar is for those patients without depression, and the light blue bar is for patients with one of those chronic physical health conditions plus depression. And the costs are about $500 per member per month more with depression, and over $400 per member per month of those increased costs are incurred in terms of medical expenditures. Similar elevations in total healthcare costs are also seen with comorbid anxiety. So this works out in a typical commercial plan with 100,000 covered lives. Patients with chronic conditions and comorbid anxiety or depression incur an estimated additional $54 million in healthcare costs per year. And integrated care has the potential to save a lot of money. This is certainly an area of growing research, but there are increasing studies showing cost savings with integrated care. The most literature is present for the collaborative care model, but certainly exists across models of integrated behavioral health. So this first study here is a review of different studies of collaborative care, and they found that there were cost savings of 5 to 10% for patients receiving collaborative care over a 2 to 4 year period. The second study is a smaller study in a safety net clinic that estimated, based on their decreased hospital utilization, that after controlling for the cost of their behavioral health staff, that they saved about $67,000 in annual net savings. And the third study was a study of 3 practices in Colorado that received a lump annual sum targeted to cover the costs of integration, with it open to practices to implement integration as they saw fit. And the net savings to commercial payers, so for public sector payers, for Medicaid, Medicare, and including the dually eligible, totaled $1 million, and that turned out to be about a 2 to 1 return on investment, and that was just after 18 months. Integrated care also improves health outcomes. This first study references a group of practices that, again, were implementing care as they saw fit in their practice, not specific to a particular model. And for patients with depression, they found after receiving integrated care, they had clinically meaningful reductions in their PHQ-9 scores, showing improved depression symptoms. The following studies are systematic reviews and meta-analyses, so they refer to composite outcomes of behavioral health. So youth had a 66% probability of having a better behavioral health outcome after receiving integrated care. And adults with depression were 31% more likely, and adults with anxiety were 41% more likely to have improved outcomes with collaborative care in comparison to usual care. Now I'll just briefly give some background for the book that I mentioned. So this book stemmed from a project called Advancing Care Together, or ACT, which was a project of 11 practices in Colorado that were geographically diverse, included large and small practices, rural and urban, public and privately owned, that all worked on integrating behavioral health in a way that was particular to their practice situation, their resources, their patient population. And they came together at the end of 3 years to talk about their lessons learned and what they would pass along to someone following in their footsteps. And it's those lessons from early adopters that we covered in our book and that we'll talk about in the rest of this presentation. Those lessons learned we mapped out into themes following this sequence that I have shown up here on the slide. I'll break these down further as we go along, but just to read through. First is frame integrated care as a necessary paradigm shift to patient-centered whole person healthcare. And then what we called initialization. This is the idea of defining relationships and protocols up front, knowing that over time they will evolve out of necessity. And then finally, in the last 3 boxes on the right, build inclusive, empowered teams as the foundation for integration, develop a change management strategy of continuous evaluation and course correction, and use targeted data collection pertinent to integrated care to drive improvement and impart accountability. So I will go through each of those key takeaways now, and in each of the next 6 slides, I'll review the core theme, the key components of that theme, and highlight some practical tips for implementation. So first, frame integrated care as a necessary paradigm shift to patient-centered whole person healthcare. Within this area, our ACT pioneers brought up the importance of eliminating the division between physical and mental health, both at the clinical and at the organizational level, to better meet patient needs. And then to treat integration as the conceptual and operational framework for the entire organization rather than a separate initiative. This is the idea that taking on integration shouldn't be thought of as a specific project within the practice, but it's actually a reconceptualization of how the practice is providing care as a whole. And it's a good idea as the practice is embarking on this journey to have a set elevator speech for those who are asking about what you're doing, to let them know in a quick 20-second blurb what you're doing and why you're doing it. And then initialize. Define relationships and protocols up front, understanding they will evolve. First in this area is creating a shared vision using common language that everyone understands. And the ACT practices brought up the idea of having integration as a mini vision within your overall practice vision. So if the focus of the practice's mission and vision is to have improved population health or comprehensive whole health care, to consider how integration fits within that and make sure there is messaging there that resonates with and is understood by the whole care team. Next, create and verify consensus regarding what partnerships entail. One of the ACT practices developed what they called a care compact, essentially a memorandum of understanding between the behavioral health clinicians and primary care providers on the team to have shared expectations around how care transitions would work, how a shared care plan would work, how access to services would work, and they found that that really saved a lot of headaches down the road. Next, establish standard processes and infrastructure necessary for your integrated care approach. So this is setting ahead of time those workflows, protocols for scheduling and staffing, documentation procedures, and setting up your EHR for integration. One rule of thumb that can be used here is what we've referred to as the 80-20 rule. So the idea that every protocol is not going to apply for every individual patient situation, but in general, protocols should apply to at least 80% of the patient population, and then you figure out the workarounds for the remaining 20%. And then finally, Determine the practice's financial risk tolerance, pursue funding opportunities, and commit to your integration approach. Certainly in planning to finance integration in practice, there's several things to work through. This includes determining the upfront costs and considering your own financial risk tolerance, projecting a budget over at least the next few years, and determining the visit productivity necessary for sustainability. In this process, it's important to also keep in mind the non-economic gains of integrating behavioral health, and these include greater joy of practice and clinician satisfaction as a result of being able to provide more streamlined, comprehensive care, the potential for having an enhanced reputation as a practice site for whole person care that might attract new patients, and then, of course, also having improved patient outcomes and increased patient satisfaction.
Thank you so much, Stephanie. Yeah, I really appreciate you kind of gave us the why think about integration, and also some of the how that really came from actual practices doing the work. So that really resonates. Julie, I think, as we've had some conversations, we've talked a little bit about, even with the best intentions, there's some law of unintended consequences when thinking about integrating. I wonder if you want to share some reflections from your perspective.
Yeah, thank you. I think, Stephanie, I really like what you've shared so far. You've really been thoughtful about the relationships, communication, and you've presented a really nice game plan. I am wondering, though, in the landscape that we have now in healthcare, both the benefits between behavioral health and physical health, the provider system in the community, between community-based providers and other healthcare disciplines, it's so bifurcated. I'm wondering if you can speak to a little bit about, is there a key principle that you would bring forward that helps move the different disciplines forward together, leaving aside any apprehension or, honestly, insecurities about what this means coming together as a team in one practice?
A great question, and a big question. I would say the most important thing, I think, is keeping your pole star as whole patient care and making everything about the patient. It really is bringing together two disciplines that have trained separately. They're using different language, functioning often in different payment systems. So it is merging two cultures in a way that have really not worked together collaboratively in that capacity before. And I think the guiding light there is really making it all about the patient.
The way, this is Larry, the way our ACT practitioners like to answer that question was akin to the classic adage about Chicago politics, where vote early and vote often. What the ACT practices said, involve your patients early and often in your journey to integrated care. And what that means and the effects of that has in the integration journey is everybody in the practice is prepared to unite out of doing a better job for taking care of this particular patient today. The focus on patients instead of ourselves permits us to get over ourselves and our historical divisions and our hard-won identities in both primary care and behavioral health. So I think the meta message that we learned from our ACT practice innovators comes down to that one principle: keep your patients first and foremost in your mind, and because everyone's going to want to do the best they can for that patient.
Thank you.
Thanks to both of you. Doug, I know you've had with experience with integration in terms of using a collective impact framework. So I'm wondering if you could talk a little bit about that.
Yes, thank you. I had actually been involved in a totally different project outside of the healthcare system on child obesity prevention using collective impact, where we had to work with childcare, private childcare operators, Head Starts, public school systems. And I found that that's a good framework, and I think a lot of the things you've talked about already would come under collective impact. And I encourage people to just do a Google search on that and look at the original Stanford Social Innovation Review, which is available online. But the 5 conditions are, and I think we've heard some of this already, is 1, to set a common agenda that all of your groups, let's say we're bringing together a behavioral health private practice and a family practice and patient populations. What are the common agendas? What is the common vision? And that's a discussion. That's not something you impose on people. You ask everyone involved. And for our school example, for example, they weren't interested in kids losing weight so much, but they did want more physical activity. So that became the core of our common agenda. And then shared measurement. As you collect data, if you have different partners, I think it's really important for everybody on the team to be interested in all the measurements. If you're going to look at A1Cs and blood pressure and depression scores, everyone should understand that they should have an interest in those scores. I don't want the mental health people just focused on the depression scores. The third aspect is mutually reinforcing activities, and this is where you really have to look at the team, because if this is a well-functioning team and it's a well-functioning system, the system should be greater than the sum of its parts. The corollary to that is each element of the system is not able to vary as much. You're sort of locked into your role, but you should be reinforcing each other's activities and making, as Larry's already mentioned, making things more enjoyable, less stressful. And when a team is functioning well, that's what happens. Continuous communication. From the mental health side, I can tell you we have all these issues about communicating back and forth. You really need to set up a system. Jeff Ryder and I are just looking at the American Psychological Association's ethics codes and any conflicts on integrated care. And we're going to have a paper soon, and we really didn't find any. So those of you in mental health, you really need to go back and look. Communicating with the medical providers is an essential part of your role. It's not something you should shy away from. And the last part of collective impact is what's called backbone support. And I'll define that in a moment, one of the fastest growing trends I'm seeing nationally is smaller primary care practices trying to work together with private mental health providers. And by backbone support, that means the two organizations have to look closely at what needs to be done and decide which organization is going to handle which piece. Is the primary care going to house the electronic record and the mental health people buy in? How are we going to handle scheduling? How are we going to handle billing for mental health? And that really requires some meetings with your business folks, your administrators. I think, to sum it up, in general, as clinicians, I've been working on teams for close to 30 years. As clinicians, we can come together and work very easily. It's getting all those office folks who handle the billing and the administrators, getting those on board. So I encourage you, if you're trying to bring different organizations or different departments within an organization together, to take a look at collective impact and use that as a framework to move forward. Okay.
Thanks so much, Doug. I will turn it back over to Stephanie.
Great, thank you. So I have 3 more of these slides breaking down the themes from our ACT pioneers. So next is build inclusive, empowered teams as the foundation for integration. Within this area, the ACT innovators highlighted the importance of creating inclusive care teams centered around the patients and their needs, as we were just talking about, where all members have an equal voice. One way to make the care team more inclusive is through the use of warm handoffs, introducing behavioral health services as part of the primary care team in front of the patient. And one tool that can be used in practice is the mnemonic of SSRI, which here stands for situation, skill set, relationship, and indicators. Situation being the patient's clinical scenario, why the behavioral health clinician is being brought in. Skill set, the skills of the behavioral health clinician that are particularly relevant to this patient scenario. Relationship, what the expectation will be for the behavioral health clinician and patient moving forward. And indicators, what will show the success of that relationship. So putting that all together, this could be something as simple as Mrs. Smith is having headaches that I think are related to stress. Dr. Jones is a specialist in stress management. And I hope that through working together with Dr. Jones over a few visits, you'll be able to lower your stress levels and have fewer headaches. Next, invest in relationship and trust building among the team by scheduling regular multidisciplinary interprofessional communication. Every practice will need to find the right balance of what's right for them in terms of meetings. Certainly, it's very possible to overdo it with meetings as well. Meetings related to integrated care can include interprofessional case conferences, can include your quality improvement team meetings. But perhaps the most important meeting is the huddle of the care team at the beginning of a clinic session to go over the patients coming in for the day and talk about roles and tasks. Sometimes when this is brought up in a practice, there's a little bit of pushback that everyone thinks that time would be better spent working on their individual roles. But once this is implemented, it's generally found that everyone appreciates that the work is more streamlined and there's less follow-up work on the back end. And next, find the right people for the team with the necessary skill sets, experience, and mentality. Where it's possible, it's certainly ideal to find someone who's trained or worked in an integrated setting, but with the current workforce limitations that we have, that's often not possible. In that case, it's best to look for the right personality fit. So a behavioral health clinician that sees working in primary care as a unique opportunity, who's flexible and comfortable with being a generalist. The importance of adequate onboarding here should really not be understressed either, and so particularly having the time for new hires to see and shadow different members of the care team to fully understand everyone's role. The next point of identifying leaders at all levels, I'll talk a little bit more about on the next slide. Developing a change management strategy of continuous evaluation and course correction. Within this area, the ACT pioneers talked about creating a culture open to learning from failure, cultivating support for change both within and outside the practice, and encouraging a broader scale call for integration by engaging patients early and often. What I'd really like to highlight here is that primary care practice is a complex adaptive system. It's not a healthcare factory with a standard input and a standard output, but a system that's ever changing to respond to individual patients' changing needs, priorities, and health issues. And the dramatic change in a practice of integrating behavioral health is really not just one change, but a series of continuous changes or adjustments. In a complex adaptive system, you need adaptive leadership. And to be an adaptive leader in this setting means to keep the practice set on the purpose, on the mission and vision, monitor how things are going, and adjust accordingly. Leaders will also arise from all roles on the team. There's not just one leader in a hierarchy. And it's the role of an administrative leader in this setting to engage everyone on the team, nurture others who've shown the capacity for leadership, and frankly, get out of their way to help them succeed. Using targeted data collection pertinent to integrated care to drive improvement and impart accountability. First in this area, collect data on defined priority outcomes to measure your progress towards integrated care and also demonstrate the value of integrated care to external stakeholders. You certainly don't need to measure everything, and just because something can be measured doesn't mean that it should be, but you also can't fix what you can't see. So it's important here to identify where there are gaps that are both measurable and actionable to be able to monitor progress. And it can help to start small, just prioritizing a few processes and clinical outcomes that the practice feels are meaningful markers of how well care is being integrated. Next, create feedback loops for data to inform quality improvement efforts and report data internally, both at the level of the practice for shared accountability and at the individual provider level to motivate change. One framework that can be useful here is REAIM, or Reach, Effectiveness, Adoption, Implementation, and Maintenance. Reach refers to the extent to which those who should have received an intervention did receive it. And this can be measured at a few different levels. For example, if you're rolling out universal depression screening with a PHQ-2 in your practice, the level 1 reach would be, did all patients receive the PHQ-2? Level 2 reach could then be, did those who scored positive on a PHQ-2 receive a full screener with a PHQ-9? And then level 3 reach could be, did those who scored positive on a PHQ-9 actually get connected to behavioral health services? Effectiveness refers to the impact on patients' clinical outcomes. Did their depression symptoms actually improve? Adoption refers to assessment of who in the practice has or has not embraced changes. Who is handing out the screeners? Who is not handing out screeners? Implementation examines processes to see if they're leading to desired changes. So this is mapping out processes to find out where there are issues that need to be fixed. For example, if you notice that shortly after hiring a behavioral health clinician, their schedule becomes fully booked, you map out the processes for scheduling and staffing and so on that lead you to be able to figure out what needs to be addressed. And then finally, maintenance refers to the importance of continuing to review quality markers and watching trends over time.
Thank you, Stephanie. I really appreciate that both the practices who participated kind of highlighted areas of clinical quality improvement, sort of structure and skill sets. Crystal, this is an area of your expertise, so really inviting you to kind of bring in your insights from working with practices and their teams on a lot of different initiatives.
Yeah, thanks, Julie. Yeah, my experience as a QI professional, not clinician, was guiding some organizations through this process. And so I think we've touched on so many important concepts, and I'd love to tell the story of what it looks like in actual implementation and some of the tactical ideas that have been used with some success. So I was working with an organization in the safety net, but we had many different clinical practices across a wide geography, some of which had mental health staff in the primary care clinics, though I wouldn't say they were quite co-located. They were usually on separate floors. It was like 2 clinics inside one. And we had some smaller practices that actually had no mental health professionals and not really any integrated care. And we came together, and I think, as someone touched on, creating that mini vision that reaches everyone. And we said, okay, there's a group of us that are super passionate about this. We want to make it happen. Where do we start? And we realized in linking it to the organization's like a bigger strategic aim was our way to start to embed the work that we were doing. And so we looked at where might there be some synergy. And for us, it was around diabetes. We knew the organization was focused on diabetes control. And there was a lot of resources in this. And so we said, how do we align our work with diabetes control? And how is this a way that we can bring together the primary care providers and the mental health providers? So, so we jumped on that and that kind of alignment. And then one of the ways in which we created these shared expectations that were mentioned was we had in-person group dialogues and these meetings, and they were called case conferences. And from the very beginning, right, that they were focused on patient cases. But over time, what happened is first, it was just a dialogue of creating what those shared expectations would be and the workflows, how are things gonna, the technical, tactical pieces. But over time, we use the case conferences and the focus on patients and their stories to use an iterative process to refine our processes, our communication, and ultimately build the team's closeness. And then turning into, it became more of an exchange of expertise and focus more deeply on solving for a patient's problems. But that in-person time together, some clinics were able to, give an hour, some were like really short, but always in that, let's use a patient case to work through it. And that transition from starting operationally to clinically. And then these, I think Doug touched on this, right, make sure that all the measurements are transparent to everyone, that we're working towards something in common. And so for us, we chose, the primary care measure would be around diabetes, and on the depression or the mental health side, it was going to be around depression, but we realized we had to work towards the measurement of that. And so we actually started with measuring our access to mental health to kind of reassure the primary care side that their patients would be seen, but also to allow them, the mental health side professionals, to say, we're actually under-resourced. And if we don't have the access, we need to support patients. And so they could problem solve together around those. And over time, everyone was empowered to act on all the things for patients. So we trained mental health providers to talk, like, what is an A1C, how to talk about it, how to get the data in front of you at a visit to know that that patient had not had an A1C test recently, and to encourage them to get that and the importance of that. And then conversely, on the primary care side, about when you see that, how might you support the work of the mental health professional with the patient and discussing, or, you know, depression or whatever is going on. And so, and that came back to the case conferences of exchanging that information. And for our smaller practices, sometimes it wasn't always feasible to do, we didn't have someone on site to do the warm handoffs or the huddles like we did at the bigger sites. And even at the bigger sites, we moved towards co-location of putting their workstations together. And so that the social worker was sitting next to the medical assistant, who was sitting next to the PCP, and they were all together as a group. But in our smaller locations, we worked towards how do you use the unused capacity at a larger site, and use digital opportunities. So we looked at teleconferencing, the video work, and had to do a little research into HIPAA around that. But so that we had patients who were at smaller clinic sites and did not have an embedded professional could connect to the expertise and get their needs met from staff that were physically located at another site. And the last thing I'll say is we found over time is that to really support the mental health professionals to be a core part of the team with the primary care team, they needed some more resources around population management. And this is something we had built on the side for primary care professionals, but to think about how might they have someone, maybe an experienced MA, that really looks at the panel of patients that the mental health providers are seeing and doing the outreach calls to get them into the visits, and helping monitor the outcomes and bring that data to the case conferences, so that the case conferences are driven by the team and they're actually driven by the medical assistants, with everyone else participating.
Thanks so much, Crystal. Stephanie, I'll turn it back over to you.
Thank you. In the following slides, we've broken down workarounds for managing and working within the current policy environment that exists, as well as opportunities for broader scale policy change. And we've done this in 3 key areas: payment, workforce, and privacy. Within payment, working within what's still a predominantly fee-for-service environment often means maximizing the use of available codes. So this includes traditional psychotherapy codes and newer codes that have been made available in the last few years, such as health and behavior codes for behavioral health needs related to physical health issues, and collaborative care general integration codes. Payment is also another reason it's so important to track outcomes. Showing what a practice is able to accomplish with integration can help make the case for alternative payments and facilitate those conversations with payers. Larger policy change to support integration related to payment should move towards risk-adjusted global payment methodologies for comprehensive primary care services, according to experts in integration. Separating behavioral and physical health services and carve-outs naturally creates logistical barriers to providing integrated care. And the end game here is really just not having 2 separate systems to take care of patients. For working within the current environment around workforce, as we brought up earlier, while hiring a clinician with integrated behavioral health experience is optimal, it's often not possible. And there are opportunities for integrated training programs for folks that have not worked in integrated settings. And there's also the potential to grow your own by developing a behavioral health clinician training program in practice. In rural areas, because of the increased workforce shortage issues, additional workarounds may be necessary, and that can include the use of telehealth or potentially sharing behavioral health clinicians across practices. Larger policy change in this area to support the integrated workforce can include loan repayment and scholarships to support behavioral health clinicians, particularly in rural and underserved areas, and also better financing mechanisms for telehealth. And then with regard to privacy, it's important early on in the journey to integrated care in a practice to update consent and authorization to treat forms to reflect sharing behavioral health information across team members. And it may be worth the investment to upfront invest in legal counsel to develop these. Larger policy change here could involve eliminating the requirements, such as under 42 CFR Part 2, that require written patient consent for each disclosure disclosure of protected health information when it's for the purposes of treatment. So to conclude, integrated care saves costs, improves health outcomes, and can be done even within the current policy constraints that exist. And there are lessons learned from early adopters that can ease practice's way. Given that, I want to just leave you all with a few thoughts here. Our patients are waiting. They're waiting for healthcare systems in general and primary care in particular to recognize that the mind and body are not separate and should be treated as one. Healthcare can also do more than it is currently doing to affect health, and integrating behavioral health with primary care represents a huge opportunity for progress to whole person health. And finally, this is an imperative for patients. This is how care should be. We've really been behind, and it's time we all caught up. Thank you.
Thank you so much, Stephanie. Lori, I think you have a really unique perspective because you participated in this work. So before we have a few questions that have come in, I invite additional questions to come in through the chat box. But Lori, maybe you could just share some of your insights before we go to broader Q&A.
Sure, thank you. And I'm Lori Raney. I'm a psychiatrist, and I work in rural Colorado and was one of the 11 ACT sites in this process. We had a pretty unique situation. We had already decided to move out of a former mental health building. The roof was about to collapse. We needed to build a new clinic, and we decided to build a clinic for the future. So we built a clinic that not only replaced the old mental health clinic, but also added 8 primary care exam rooms. So just about the time we were opening this clinic, the ACT opportunity, this grant came along, and we decided to join that. So we literally had the opportunity from the very day we moved in to participate. We were journaling in our experiences to the researchers as we literally went through this process. And I have to say it was quite the exciting one. There are a couple things I want to say as they relate to the specific brackets we've been talking about. And really the one that was super important for us was around this team development. And there's 2 kinds of team development, informal and formal. And the way we made the informal team development happen is we actually put a central hub in our building. So all the behavioral health and primary care people were together, bumping elbows, looking up over the top of their cubicle, talking to each other. A little chaotic, but as someone mentioned earlier, that shoulder-to-shoulder mental health and primary care, it really fostered a lot of that informal team development, going to the huddles. Those were the things that were super important. And then from a formal team development side, we did make the time, and there is that pressure not to take away from clinic time to have team meetings, but our organization made the decision, even though it was Wednesdays at lunch, bring your lunch. It was not made mandatory, but we started having these team meetings where we discussed patients. And before long, I really think there's something to be said for how teams develop over the eating of food, because our teams, we were there, more and more people started to come. We're friends, we're eating together, sometimes we're biking afterwards. It was just amazing what began to happen because we really did set down time and were very intentional about the team development. The second piece I would say is around leadership. And what happens when you start an integrated project is you have a couple people in your organization that, are innovative, they want to do this, they signed up for the grant. And in your organization, you have to be careful to let go a little bit of there's a group that's the innovators and everyone else needs to follow along, because as you get going, the people in the trenches, the bubble up of ideas and experience is really, I think, where the magic occurs. So for those of you that are doing this, keep in mind, yes, they're the innovators, but there's all the informal and experiential stuff happening with medical assistants, behavioral health providers, PCPs, and others. So just sort of keep in mind what happens in that transition from those who help you get started to those that are actually going to help you be successful over time. The other thing that was mentioned was, how do you get an organization to fully embrace that your behavioral health providers see whole health, your physical health providers see whole health? And there's not a lot of separation. I actually was having a conversation with someone yesterday about how even dental belongs in there. And one of the things that we did early on was we had a health fair. And everybody, no matter primary care, behavioral health, whatever you are, they came in and they went through the process. So we had therapists doing vital signs. We had, everyone had to do the PHQ-9 and the GAD-7. Everyone had to have their BMI taken. And it really, for our organization, was a launching pad for really embracing whole health. Someone mentioned earlier, once you set those metrics belong to everybody. So if it's about diabetes, the therapists who are treating that patient's depression also need to be focused on that patient's A1C. And it was amazing to see what happened. We put a vital sign station over on the behavioral health clinic side, and our therapists were doing vital signs. We'd have kids coming in for a play therapy session, and they were, audibly wheezing, and the therapist would take the patient over to see the pediatrician. They would stop that. So it was no longer a play therapy visit. That kid really needed to see the pediatrician. That was really what needed to happen that day. And to get your staff to see that and buy into that, it's magical when you see it to happen. It's quite magical. The last thing I want to just say quickly is from the financial sustainability side, we were also doing a bidirectional or reverse integration project. I, as a psychiatrist, my office was placed in the middle of primary care. I could walk my patients with schizophrenia right to the next exam room and have them be seen for whatever was going on. And that piece was in particular very difficult to sustain financially. And we ended up becoming an SQHC, applying for SQHC status and doing that as a way to make that piece of it financially sustainable. Otherwise, we were doing a lot of traditional billing, but in integrated care, there's a lot of stuff that you do that's not billable, hence the struggle many people have in sustaining their integrated care process. And just in conclusion, this was a great project for us. I personally learned a lot, and am very grateful for the ACT folks that ran this and supported this project. Thank you.
Thank you, Lori. I'm really struck by your comment about eating food together. I think just recently, I believe it was in JAMA, there was an article that talked a little bit about that how it eating together sort of supports the team dynamic. So we have some questions that have come in, and we have about 10 minutes, so we'll try and be efficient to get to some of these. But I think I'll direct this one to Larry and Stephanie. So we have a question from Peter, and he talks about, with the emphasis of creating teams with the objective of really meeting patient, person, and family-centered needs, how long can you be expected to continue without sort of that constant reinforcement?
I think I may not understand that question, Julie, but I think you're saying, you got to be reinforced to work on these teams. And sometimes there's a change agent on the team that is feeling very lonely. And I guess it's a resilience question in a way. That's going to, in my view, that depends. That depends on the situation. But the point I would correct us back to is everyone leads. In the integrated care journey, everyone leads, not just one or two people. And when the entire practice shares that vision, who can support the person that's a little worn out and a little tired, there's a number of candidates at the local level in the practice who can step up and support that person. There's also organizations like the PCPCC and like the American Psychological Association, like the Collaborative Family Health Association. Having membership and attachments to those organizations is often a really good renewal mechanism. I apologize if I didn't understand the question correctly.
And I'll just add in there too, again, not sure if I'm interpreting the question right, but I think it's important from the start to really be focusing or to really celebrate successes and celebrate early wins too. Bringing up, in particular, patient stories like at all staff meeting to highlight those successes can also really keep that motivation going and keep the mission and vision alive for the whole team.
And, you know, I think I would add to it that I think similar to your thoughts, Larry and Stephanie, that it almost takes constant care and feeding. I don't know that you're ever done. So you may feel that you've reached different stages, but at each stage, then, you know, there's just continually looking to see how the team is functioning. You get new people on the team, so there can be a little bit of an ebb and flow. You get different patients, you're working on different elements. So I think it's something to be watching for all the time. We have another question from Shamika, and I'm going to open it up to the group, and whoever answers first is the one who gets the question. A little like a game show. So for those patients who've scored positive on the PHQ-9 and were referred or connected to behavioral health services, there's a question about being able to track the linkage to appropriate services to confirm that the needs were met. So kind of using PHQ-9, but also creating the communication back and forth to understand that the integration is really working. So.
Well, this is Lori. I'll just add one piece. I mean, I think there's one thing if the behavioral health services are all in one organization like we had, because I'm a very strong advocate of measuring care and response to care in primary care as you're getting started. So that first PHQ-9 in the primary care clinic, maybe even a second while you're waiting for the linkage to occur. And then once they get to behavioral health, that it is the practice also in specialty behavioral health that the PHQ-9 be continued. And so that was our process. We were able to look at it internally. I think externally, when we refer people out, behavioral health is a slow adopter of measurement-based care. And so repeating PHQ-9s and GAD-7s and PCL5s for trauma or Vanderbilts for kids with ADHD, behavioral health has to catch up with this in this measurement-based care world. And so having some agreement with your partners that you're referring patients out to, that they will continue that process and feed back that information would be extremely important. And that could be developed in a care compact or an MOU or something that you might be doing with an external provider. But if it's internal, and I see this in integrated settings, the therapists who are picking up the patients aren't repeating the PHQ-9, but in primary care they are. So just make sure there's a connection if that's all, for certain, if it's all internal.
Well, Lori, I would chime in there real quickly that in our ACT practices, they actually fell in love with the notion of actually written compacts between the caregivers in their integrated system. And that question fits tidily and very directly into what was called just reaching agreement about collaborative care management. And there are mutual duties and responsibilities here that do well to be spelled out for the primary care providers and the behavioral health providers in the integrated system. So, who is going to be responsible for that person's follow-up care? When will the care be passed over to someone else? What are the circumstances of that? Who records what was rendered? How does that record get shared? Those are elements to discuss and define specifically, and it can avoid a lot of difficulties. It also is professionally necessary because we have a duty to these patients to not just identify them and leave them stranded. We need to close these loops. There are tools and techniques available for integrating practices to just have check boxes and say, well, that one's mine, but the next one's yours.
Thanks to both of you. I think I'll give the final question to Doug. We actually received some questions before the presentation, and in my mind, they're a little bit like Maslow's hierarchy of needs, and they were really about, you know, financial. And Doug, I know we had a little bit of a conversation of the payment structures are moving. There's fee for service, but then there's also the transition to value-based payment. So I'm just wondering, in our very limited time we have left, if you could just, you know, give some perspectives about how to manage that changing landscape in terms of payment.
Yes, thank you. I know in the first part of the presentation, when Stephanie was talking about or giving examples of programs, one of the Colorado examples, they actually did pay the mental health providers out of a per member per month payment. We don't have a lot of time to talk about it, but fee for service is fading, not quickly, but fading. Practices in some of the new models for primary care are going to include per member per month payments. And one of the questions is, do you pay for your mental health services out of the per member per month payment for your basic care management and some of your basic therapy and screening services, and then add some additional billing on top of it? So I think whenever a primary care and a mental health group needs to get together, they ought to look at that, see what the insurers are willing to pay per member per month. A really interesting practice here in Delaware, Mid-Atlantic Psychological, actually has a contract with Medicaid where they're going to get a per member per month payment for patients diagnosed with severe and persistent mental illness. So they're going to get a care coordination fee just for those patients, as long as the nurse manager is keeping track of those patients and making sure they get what they need, and they are connecting them with a family practice group here, sort of a reverse integration done through a mental health program. Besides those sort of capitated monthly payments, measurement is critical, because a lot of these payments are going to include payment for quality and outcome. And as a last example, I saw a very nice example through CMS of a pediatric group in Jacksonville that met all of their quality goals. They had a consulting child psychiatrist, they had 2 psychologists, they had hired 2 nurse educators, and they got a pretty massive 20,000 patient practice, got a total of $1.2 million at the end of the first year for meeting all their quality goals. And when I talked to the pediatrician who is the principal of that group, he said fee for service, our psychologists and our psychiatrists didn't cover their costs, but with quality payments like that, we more than cover the cost. So it really requires some creativity and an understanding of all the payment models that are out there. And, you know, when you design your program with your patient, again, patient-centered in your design, what are the goals for the patients? How can we best meet them? Who do we need to hire? And what kind of revenue can we expect, either in a per member per month payment or in quality and value payment?
Thank you so much, Doug. And I really want to thank all of our experts, Stephanie, Larry, Julie, Crystal, Doug, and Lori, for such an engaging and interactive presentation. And thanks to all of you for joining us today on this webinar. You'll find some additional resources from our panelists on the remaining slides, and they will be available for download on the PCPCC website, as well as the recording will be posted there. Please keep a lookout for other PCPCC events, and thank you for your time today, and also consider becoming a member of PCPCC. Thank you and goodbye.